And now we're going to move on to the Clostridium species. So these are all anaerobic bacteria, and the first one we're going to talk about is Clostridium tetani. I'm sure you've heard of tetanus, so you know what we're going to be getting into. So shared characteristics of the Clostridia species. So they're all gram-positive rods, and they form spores, and they're obligate anaerobes. They cannot survive in aerobic climates. And the reason why is they don't have the enzymes necessary to deal with oxygen radicals. So the second you expose them to oxygen, they're completely gone. They all produce unique exotoxins. We'll talk about each one individually. And now we'll talk about Clostridium tetani. So this one is found in the soil. And since it's found in the soil, after natural disasters like an earthquake or a tsunami, which open up the soil and expose more soil to the surface, the Clostridium tetani can go into the air and spread its spores, and there'll be higher risks of infections. The exotoxin that's unique to this one is called Tetanus Tasman, and the way it works is it prevents GABA and glycine release from Renshaw cells. So remember, GABA and glycine are inhibitory neurotransmitters. So if you prevent GABA and glycine release, what's going to happen? Activation. You stop inhibition, so guess what you get? Activation, especially of muscles. Who's at a high tetanus risk? Anybody with a penetrating injury? With a penetrating injury, the spores can inoculate it into the blood and into the tissues, and that can cause C. tetani to grow and produce toxin. And the classic example is the rusty nail. I'm sure you've all heard of this example, the rusty nail. Watch out for rusty nails. Foreign bodies, such as a splinter, so tetani can grow in the splinter and the spores can germinate. And also neonates, if they have an umbilical stump infection, that can also cause it. And obstetric patients with septic abortions. So if a patient has a delivery at home and uses some kind of weird products on the umbilical stump through a cultural reason, can get an infection in Clostridium tetani. And also septic abortions are a risk factor for Clostridium tetani. So the diagnosis, the classic clinical symptoms, you'll see all of them soon, the muscle spasms and all the other problems you get. So generalized tetanus. This is what happens about 7 to 10 days after the exposure. So it doesn't usually happen immediately. It takes a little bit of time for it to happen. So it presents with what? Autonomic instability. So this is surprising. Why do you get autonomic instability? You have activation. So you get even activation of the sympathetic nervous system, causing tachycardia, sweating, restlessness. And now here's the good stuff. The muscles all get hypercontracted and hyperactivated. So you get a spastic paralysis, trismus or lockjaw, rhisis sardonicus. You have a sarcastic smile with raised eyebrows and an open grin. Opisthotonus, that's where you have your back arching and back spasms. Upper airway obstruction, because the upper airway muscles contract, and that can cause respiratory failure. So now you have neonatal tetanus. So this is generalized tetanus, usually in adults. We also have neonatal tetanus that happens in these cases we talked about before, neonates, and it happens about 5 to 7 days after birth. So what happens, you get a contamination of the umbilical stump in poorly immunized mothers. So if mom is not immunized and does some kind of strange treatment of the umbilical stump, that can cause major contamination and tetanus exposure. So there are different kinds of things that can be done to the umbilical stump. They can put dirt on it, straw, cow dung to cause it to stop bleeding. All of these increase your risk of tetanus. They could be contaminated with soil and spores. And also non-sterile surgical tools, they can have tetanus spores on them. So symptoms that the infants get are refusal to feed and difficulty opening the mouth. Remember the trismus, lockjaw, so they can't feed. Inability to suck, so they can't breastfeed. Clenched hands because of the muscle spasms and hypertonia. These are some symptoms you should know. So how are we going to treat these patients? So first thing is if we have a wound, remember we have it from a high tetanus risk from a penetrating injury or foreign body, we need to debride the wound to eliminate the spores in the necrotic tissue. Remember, this necrotic tissue is a perfect site for germination because it's lost vasculature. And remember, these are anaerobic bacteria and they'll grow in anaerobic conditions. So you need to debride the wound, clean it up, remove it, to get rid of the spores and all the bacteria living in there, and get rid of the dead tissue that the tetanus likes to grow in. You also give IV metronidazole or penicillin G. Remember, metronidazole is always very good against anaerobes, and penicillin G will cover the cell wall in the anaerobe as well. Remember, it's gram-positive, so it has peptidoglycan. Penicillin G will take care of that. Treatment also is human tetanus immune globulin. This is preferred over the antitoxin. So in the U.S. and first world countries, we're going to use immune globulin to handle the tetanus, in addition to debridement and antibiotics. So they need 3 doses of the tetanus vaccine because there's no immunity after the acute illness. Okay, so if a patient gets tetanus and has no history of tetanus vaccine, they need 3 doses of it because you don't get immunity after the acute illness. It's kind of an interesting condition that way. Even though you get an infection with the Clostridium tetani bacteria, you do not develop a natural immunity, so you need the vaccine to have prevention of future occurrences if you haven't been vaccinated. Another thing is you give diazepam, a GABA activator, for the muscle spasms to relax the muscles. So now we'll talk about tetanus vaccine and immune globulin. So vaccination, remember we're always going to be hitting vaccines here because those are very high yield topics. Vaccinations are given to infants and children up to 6 years old. And they're given at these different intervals, which you don't need to memorize. Remember, DT means diphtheria, tetanus, acellular pertussis. You don't need to memorize these. Just know that they're given to infants and children in 5 total doses. Also, contacts of patients affected with tetanus, diphtheria, or pertussis require immunization if underimmunized or immunized. So contacts of exposed patients, if they don't have a full vaccination history, need to be vaccinated. Some absolute contraindications to tetanus vaccine are anaphylaxis to the vaccine. So if you have anaphylaxis, you don't want to give diphtheria, TD, or Tdap because of the high risk of future anaphylaxis and possible death. If you have encephalopathy secondary to the vaccine, such as seizures or altered mental status, you don't want to give Tdap. All right? If you have encephalopathy, you can still give TD, but no Tdap. If you have anaphylaxis, don't give either. What if a patient has seizures unrelated to the tetanus vaccine, like a history of seizures? Can they get it, an adult? Yes, they can. So if you have a patient with seizure history that wasn't related to the tetanus vaccine, you can still give the tetanus vaccine. Only reason we're not giving it is because this is what caused the encephalopathy. Also, if you have an infant with uncontrolled epilepsy or infantile spasms, you don't want to give Tdap as well. All right, only if uncontrolled epilepsy. If the seizures are controlled, you don't need to worry about a contraindication. But if it's uncontrolled, don't give Tdap. Vaccination in children also happens between years 7 and 18. You get 1 booster dose between 11 and 18 years old. So even if they have a prior immunization history, a pregnant girl has to get an additional Tdap dose, even if they got a full immunization. So if a patient is between 11 and 18 and is pregnant, she needs an extra dose of Tdap to protect her and the infant. Vaccination in adults, a TD should be given every 10 years, and 1 of those should be a Tdap. Very, very high yield to know is this topic over here. 1 dose being Tdap. So now let's talk about what happens during wound management for tetanus prophylaxis. This is a very, very important topic that you have to know, and it's very commonly tested. This was on multiple tests of mine. So clean minor wound with poor vaccination history or unknown vaccination history. What are you going to do? You're going to give the vaccine with TD or TDAP. So clean minor wound and in poor vaccination history, vaccinate. All right. If you have a clean minor wound with good vaccination history and good previous doses given, only give it if it's been more than 10 years since the last dose. Remember, that's the normal indication. You should get it every 10 years. So if you haven't gotten every 10 years, vaccinate them at that time. So clean wound and good vaccination history, vaccinate if they haven't been vaccinated in over 10 years. What about a dirty wound with very poor immunization history? This is where you give vaccination and immune globulin. So vaccinate with 1 of these 2 and give the tetanus immune globulin. This is the only indication of the wound management where you're going to give the immune globulin. And what if you have a dirty or significant wound with greater than 3 doses given in the past? That's when you give the vaccine only if it's been more than 5 years since the last dose. So if they have good vaccination history and a dirty wound, vaccinate if it's been more than 5 years. So if they got a dose 7 years ago and they have this kind of wound, they need to be vaccinated.